Good afternoon. Welcome to this Meet the Innovator session entitled Are All Outcomes Equal? It comes as a continuation to this morning discussion about outcomes that matter to patients and will focus on the case of a clinical study which led to unexpected outcomes. My name is Ilaria Leggeri. I am Citizen and Patient Engagement Manager at EIT Health, and I'm joined in this conversation by Professor Alison McGregor, Professor of Musculoskeletal Biodynamics at Imperial College London, as well as Anya Henley, who at the time of this story or study was the clinical trial coordinator and is today advising EIT Health about societal impact. So may I start this conversation by asking Alison, can you tell us about this study and what was the context and why you thought it was necessary?
So this study has quite a long history. It was done 10 years ago, but it actually goes much further back than that. It almost relates right back to my PhD, where we were looking at back pain and spinal surgery. And it kind of came about from the observations I had in clinic, if you like. So I would see these patients who'd been operated on and be trying to get them to take part in a study. And the professors and the surgeons were, just absolutely delighted. This is marvelous. This operation's gone so well. And yet there'd be this patient sitting in the clinic in tears going, I have awful pain. I can't move. I can't do anything. And there was this big disconnect between what they thought was a good outcome and what the patient thought was a good outcome. And it took me a long time to realize that what the surgeons were happy about is they had done a technically competent operation. They'd seen something, they'd operated on it, they made it better, but it wasn't actually improving the patient. So I suppose from that, the study started emerging.
So this was an exercise which was motivated by clinical needs, and if I understand correctly, and how was this designed? How was the trial designed?
So what we wanted to do was develop an intervention to make the patients better. And we knew that the surgery damaged the muscles of the patients, and we knew that patients were deconditioned or unfit, if you like, because of the back pain they'd had. So we looked at developing a physical intervention with elements of psychology within that. When it came to ethics, we were told that actually just comparing that to usual care wasn't really ethical, even though the normal usual care, which is nothing, is reality. So we had to design an educational booklet that went with it. So it became a factorial design study. So we had you either got a combination of the intervention and information, or just information, or usual care. So that, or just exercise. So there were 4 different interventions, if you like. And then, what we then had to do, because we had in our minds what we needed to do for the physical intervention, we then had to design this educational booklet. And again, I suppose this taps into the sort of fashion that happened, you could argue, in research. And at that time, everything being delivered clinically had to be evidence-based. So the perception at the time was that if you want a patient to listen to you and to do the right thing, information had to be evidence-based. So it wasn't about what the patients needed, it's what the evidence told us. And of course, on this subject, on what you should do after a spinal operation, there wasn't much evidence. So what we put together was evidence-based, but you could argue, I would look back now and say it's a bit woolly, because it just says things like exercise, be active, don't rest at home, don't lie in bed. But that, from a patient perspective or a user perspective, probably that even then wasn't quite enough.
And actually, it was quite obvious, wasn't it, when I used to speak to the patients, that it wasn't really, well, it wasn't obvious, but we did communicate. I did communicate a lot with the patients throughout, because sort of trying to get them to answer their outcome measures that we sent them, questionnaires, etc. So it was fairly not obvious, but I could recognize that in my communication with them.
And I think it's true. It's whatever you tell people, they always want more. And what we think they need answering is not always what they want answering. And I think
exactly.
As a profession, sometimes medicine has this habit of assuming we know better than you what you need to know.
But actually, can I just say, Laura, this is what in a way pushed me to do what I'm doing now, which is pushing the patient as a voice pretty much everywhere, because I heard so much of this during this study that Alison was running, because it just from what we discovered, and Alison is going to tell us, it really is the voice of the patients that mattered most.
Right. So, well, that's interesting and made me curious. What exactly did the study find? What did your study tell you? Your clinical, originally very clinical study.
So the study was designed to look at functional outcomes. So did people have a better quality of life, and could they do more in terms of things like disability? So stuff like that. And what we actually found was quite a mixed message. So we found that the people who got exercise only seemed to do quite well, but if you gave them exercise and the education booklet, they did worse. So it's a bit like that, the information we gave them held them back. And then it also seemed to be discriminatory between your age group. So if you were younger, you seemed to do better with just being told what to do. If you were older, you needed to come in and have physical classes for exercise because you needed that reassurance and that guidance. So it was a very mixed message, and it didn't quite make sense, because we really had thought that these were patients who were deconditioned, they were unfit, they had had their spinal muscles operated on, they weren't strong. We really thought that the interventions would make them better. And from talking to the patients that went to them, they loved them. They really valued the intervention. In fact, many of them used to ring up and say, can we still keep coming beyond the 12 sessions or whatever it was? So it just didn't, what we found didn't make sense with what we expected to find, and from what some of the anecdotal information we were getting from the patients.
We basically, I mean, it was very interesting, because the exercise regime they were getting, it was well, regime. There were classes. They were very important to them. They were not just doing physiotherapy with a physiotherapist, obviously, but they were able to communicate with each other, etc. So you would have, for me, it was sort of like obvious outcome without sort of even thinking of the statistics and the results, wasn't it?
And I think part of it, Anya, there were two things. Is not everyone came to the class. So it was quite interesting, because when you approach patients to take part in this study, they were astounded that this wasn't part of normal care. But then when it came down to it, a lot of them then didn't bother to come to the intervention. But yet once they seemed to come to a couple of them, they loved it. And it was what we call a rolling intervention. So people joined at different time in their recovery journey. So that was actually quite motivational, because they fed off each other.
Yeah.
And what was really beautiful is these groups of people going through rehab formed friendship groups almost. And they met,
we found later on
before and afterwards,
yeah.
and they're still in touch after all those years. So it was more than just exercise. There were lots of, they had a session which I always called the stitch and bitch session, where they moaned about their GP or their surgeon, or they didn't get scanned early enough, or whatever it was. So there was a lot of mutual sharing and mutual understanding, but then the data didn't really reflect that. But of course, the outcome was disability and function. It wasn't what they want, it wasn't, did you have a good time? Did you feel better? Did it make you feel supported? And that maybe is part of the problem.
Yeah. It was, I just find it extraordinary that, by the way, we forgot to say that it's in the UK that they don't get any rehab, or didn't get any rehab after treatment, after surgery, didn't we? Because some other countries do have.
Yes, some
rehab.
countries do. Some have very extensive, but some don't.
Some don't. Exactly. So
and you need trials like this to try and change clinical practice, unfortunately, and provide that provision. So what people think is obvious isn't always there for them. And I think that's also quite interesting, that, and I can see the patient viewpoint. Why wouldn't you have something to make you recover? But it's not there.
Yeah.
So if I can summarize up to now, what I understand is that you went in with a very medical perspective. Is my surgery, is the outcome of that correct? From a functional perspective, how are people doing? And when you were coming to the end of that, you had a sense that actually there was more to this story. Is that right?
Yeah, there was an awful lot more. And we had quite an insightful trial steering chair, and he kept saying to me, you need to explore what it is, why only half the patients came to what they perceived the interventions to be like. And then he actually said, maybe look at how you could find out what the patients got from being part of the study. So we evaluated both interventions with surveys and focus groups, and actually the response was really positive. So although I was a bit self-deprecating about the evidence-based booklet, the patients did actually like it. But what they said is, we want more of those tips of the day. We want more specificity in the exercise. So we don't mind you telling us to exercise, but tell us what, how often, what routine, what approach. So they wanted everything, but they wanted more, and they wanted more specifics. And whereas we'd held back on specifics because of evidence, they didn't care about the evidence. They just needed guidelines. And I suppose that rings true today with the pandemic. People just want to know what to expect when, so they know how to handle it. Dealing with uncertainty isn't people's strong points. And then when we talked to the people about the exercise, some said, well, once I knew it was something I should think about, I used to exercise before, so I put my own regime together. Or some people had interesting perspectives on how far you should be prepared to travel for an exercise intervention. So there were all sorts of logistics around timing of it, but people did like the interventions. The older generation liked coming in person because they wanted the reassurance that they were doing it correctly. So they didn't like being left to do it alone, because they wanted somebody to just say, that's okay, you're doing it fine, keep going, you're not doing any harm. Whereas younger people were a little bit more gung-ho. But I think when we actually did the focus group about the whole experience of the surgery and what had happened to them, I suppose it was a chilling message, and it was quite a saddening message in terms of healthcare provision, because what the patients said to us was, if it hadn't been for this study, we'd have felt totally abandoned.
And this is, if I may interrupt, Alison, this was, I mean, it was quite early to do focus groups, wasn't it? We were actually, I'd like to say, just to push a little bit I'm not quite sure how you say, but to push a bit, put over our non-modest comment, is that we were quite early at putting focus groups together. And they were so keen, those patients, to share their experience. It was very, very interesting. And I don't know if, I think this is something that we're speaking now more and more about focus group and what they bring, and getting not only focus groups together to get what they experienced out of this. And this brings us to what we did later on from the results of these focus groups and what we looked at, but also that we brought them back again further on the line. So we've really sort of involved those people who gave us that, the explanation, Ilaria, about this extra mile that we're talking about. We actually asked them to help us develop something later on. And I think this is the advantage of our focus groups. You know, if you really involve, but actually during the clinical trial, I did speak to a lot of people. I did contact them regularly. I sent them newsletters. I was really keen on making sure that those people understood that we were not just studying them, but they were part of a study, and that the outcomes would be really looked at. And I was so proud to be able to be part of something that we were able to notice, isn't it? It was a very interesting experience at that time. So
you were being quite progressive in a way, because you basically started from a medical angle. You got a glimpse of, wow, there is more to this, and what actually matters to people, which is going also to have an influence on the clinical outcomes, is something else. And you started to work with people to understand exactly. And so how does this evolve? I mean, you obviously kind of, in a way, unveiled a reality which you hadn't anticipated. And so how did you, progress in that?
So I think it's about listening. So we had to listen to what the patients say to us was important. So I think it goes back to thinking about your own perspective and reflecting. We did this for this reason, because we wanted to know the care pathway and what would be best for the health service to deliver. But actually, we'd never thought to talk to the patient about what was important. And it's funny, I was just thinking as you were speaking on every time you fill an ethics form in, there's a section on will you personally benefit from taking part in this research? And we're always saying to the patients, you may not personally, but it would help the next person that comes after you. And what really became clear is that people did want to make it better. And I think with something like back pain and spinal surgery, there's a real desperation. These are people who really are quite disabled with their pain and their situation, and they're prepared to try anything. But it made us see that there might be better ways of managing them and helping them through this journey and this pain disability journey that is there, and that whilst it's becoming ever more clear that we can't take their pain away, we can improve their quality of life. And I think to do that, we really need to know what things matter to their quality of life. And we used outcome measures in that study that were designed in 1980. And even by my standards, 1980 is a long time ago. I was still at school. So, we're using metrics that we just happen to have. And I suppose it's the cycle of clinical trials, or the way we approach research. You need a robust outcome measure. You need someone to have used it before to power your study. And also, we almost make it too hard to progress there. And I suppose everyone thinks that qualitative research is too hard, and it's a bit woolly, and it doesn't give you anything, but actually it can really highlight some common themes and areas that we can improve. And I suppose that's what the focus groups did for us. And what we then wanted to try and do is not try and tell the patients how to get better, but steer them with the right advice and support to enable them to transition through a patient journey to recovery. And do that by maybe taking the things that they valued from the trial. So interaction with other people in the same situation, knowing how hard to push myself, how somebody should be doing in this situation. Mm-hmm. So that's what we tried to look at. And really the main outcome there would be patient experience, but that in itself created a whole load of problems for us.
But it's true as well that it's such a huge problem, isn't it? Pain. Back pain is a big economic problem as well, societal problem. And I think not only did patients want to make things better for themselves, but also they actually, the problem from what all the talks I had with the patients, but also on our second trial, on our further trial, that when we involved somebody to actually be on the steering committee throughout, etc. And it was the fear of getting this pain back. Whereas if we look at what the patient really matters, then they will feel more satisfied about what they got out of the intervention. And therefore, you will have less coming back and less people sort of using facilities or using doctor time or hospital time.
So do I hear it right that at the time when you were running this 10 years ago, no one was asking you to look at the outcomes that matter to patients, and you somehow almost stumbled upon them in a way?
People were starting to look at things like patient satisfaction, and we did try and look at patient satisfaction in a very crude way. But of course, you need to have a whole study just looking at satisfaction, because patients can be satisfied with a whole range of things. They might be satisfied that the nurses and doctors were really polite to them. They might be satisfied because the hospital was clean and they had a nice room with a nice view of the Thames. But then that's separate from being satisfied with the outcome. So satisfaction, what we did was the start of this kind of probing what patients really want, I suppose, and what matters to them in a very crude way. But it was at that time too superficial, and people weren't really thinking, what does satisfied mean? And how do we stratify it? It's satisfied with the outcome of my surgery, satisfied with what exactly? Because the thing that this study also revealed on, or one of the earliest studies that led to it was, whilst patients weren't satisfied with whilst the outcome was bad, patients were moderately satisfied. And when you do that old test that I often do with students when they misbehave is, in hindsight, was that the right thing to do? Which probably all of our parents have done with us at some stage in life. I said to them, in hindsight, knowing where you are now after this operation, do you think you made the right decision to have surgery? And almost 90% of them said yes. And I was really gobsmacked, to be quite brutal. But then when I went away and thought about it, what this is a reflection of how desperate they are to move on in their lives and get some improvement. Because when I talked to them a bit more and said, why did you say that? Because it just doesn't make sense to me. I was always taught by my good Presbyterian parents from Scotland that hindsight gave you a better thing and you'd have behaved differently if you'd known that. And they said to me, the thing is, I'd have always had it in the back of my mind that surgery could help me. And this could help me move on and go and do the things I wanted to do. So I had to try it to know it didn't work so I could move on. And that seems a very dramatic way to move on in your life. And surely there must be better ways we can share that journey with people who've been through it and make that better, to save them going through I don't know whether it's the
But
stress.
if I may say, you were
the
also
journey.
fairly unusual as somebody leading this study in the fact of asking all these questions, because, as you say, you had a very enlightened steering chair. But I think, and actually, we were amazing. We were an enlightened group as well, we must say, because everybody who was
Eclectic and
involved.
So it
Yes.
would seem.
Yeah.
So can I so this was very insightful to me, and I would imagine to our audience as well. I would invite them, we have 5 more minutes, so I would invite anyone who would have any questions about, you know, how you started on one end and somehow almost got to another end, to ask questions in the chat that we can then look at while our audience is thinking about those questions. Perhaps something that you know, I would like to ask you. So obviously we've seen how you started this. You did this exercise at a time where it was not like a thing. So it was not, today, hopefully people are thinking about outcomes that matter to patients is more of a mainstream, but at the time this was not necessarily your mandate. How would you think that running this exercise today, how do you think that things would have changed? Would you have started from another end? Would your mandate have been, you know, what are the outcomes that matter to patients and see how that leads to the clinical outcome? Or
Yeah, no, it's funny you should ask. So I have a young trainee doctor wanting to do a project with us. He's a clinical registrar or something, and it's about a different type of spinal surgery. And we were talking about the outcomes, and I said the trouble is, it's exactly the point I made earlier. These outcomes were designed in the 1980s. Are they still relevant? And I think the biggest area of research now is how do we capture what's important to patients? You know, it comes back to the title, are we actually capturing the right outcomes? Because, you know, often, especially with something like chronic pain, is we don't make the pain better, but they might be able to do more of the things they want to do with the interventions we offer. So we might not change their pain levels, we can't make their problem go away. And in many ways in medicine, we manage pain and disability, we don't cure it. But what can we do to make them get more out of their life? What can we give them a better quality of life? But most of our quality of life metrics revolve around daily activities. And actually the things that give us the boost in life, it is going out with friends. It's all the things we can't do at the moment in lockdown, to be honest. But, you know, it's those things, but we never capture those in outcomes. So how do we capture what's important to patients? Well, we have to ask them what's important. And we also have to accept that not every patient's going to tell you the same things. There has to be some tailoring of those outcomes, because
and they might also change. You've got to also understand that they might change what the outcome is after the interventions, because
and also
they
as
might
they get older, you know, your priorities change. You know, it might be before you had no children, now you've got children, and you know.
Exactly.
I think a really nice example is I do a lot of work with military veterans, and one of them's a bilateral amputee. He's also a Paralympian, but the thing he would really, really like to be able to do is carry his daughter upstairs to bed.
Yeah.
But he can't walk up the stairs carrying a load.
Gosh,
and it's those little things that you don't think about, you know, and it's not, we would just say the fact that he can walk up the stairs, isn't he happy? But he can't carry his daughter and put her to bed when she falls asleep in his arm. And that's quite an emotive thing.
That's
an
very
amazing,
emblematic.
gosh, yeah.
Anya.
Thanks for sharing that. Wow.
Absolutely. And actually, Anya, this prompts a question for you. I mean, you've worked a lot with patients in the position you had at Imperial College, but you continue to do so. And would you say that today, so obviously, I mean, we get from all this conversation and what we had this morning as well, that we need to work with patients, but how easy or difficult is that? And to which extent are patients, you know, is the culture evolving also for patients to be contributing more on this end? And we have 1 minute. So that would be almost a wrap-up line.
Oh, right. Well, I'll be very quick, but I think patients are more and more educated. We're all more and more educated. We can go on the internet, we can find things out. But the other thing is, I think we've become more demanding as a society. We're actually asking for results. We are more, the other thing is, it is our democratic right, putting my Elsie hat on, to actually get what we pay for. So all these things I think are quite important to put together, and in a way, this is what I think EIT Health is doing. And I really do think this is a very not only important to the patient, because to me it's a win-win situation. If you get the patient to actually get what they want, but also society actually not having to pay further down the line for complications because they didn't get what they want,
Yep.
then it's a win-win situation.
Thank you, Anya. We have to say goodbye now. Our time is up, but I think we had lots of very interesting topics and lots of good vibes also for our audience. And thank you so much for sharing your story with us.
Thank you.
Thank you.